No
Camera
worries.
is my,
Okay.
it's my, okay.
Yes, yes. No worries, no worries. Yeah, it's okay. Do what you need to do. That's fine. I thought it was somebody else. So no worries. And Ashkan? Ashkan?
Hi, my name is Ashkan. I'm a fourth-year medical student at AUIS, situated in Barbados.
Okay.
Currently, with the pandemic going on, stuck in St. John, New Brunswick.
Okay.
Hopefully, trying to finish off my fourth year and apply to internal medicine and family medicine as a backup. I did some emergency medicine rotations out here where a lot of imaging knowledge was required. So I'm very happy to be doing this elective and gaining a new insight as to how to interpret different sorts of image modalities.
Awesome, awesome. Well, welcome. All right. Huria, how are you?
Hi, I'm good. How are you?
Hi. Good, good, good. Welcome. Tell us a little about yourself. Yeah, so everyone knows.
Hello, I'm Huria Shamail. I'm graduate of King Edward Medical University in Pakistan. I just completed my one-year internship here and I'm going to apply in radiology residency this year end. Then I'm excited to be here. Thank you for having me.
Welcome, welcome, welcome. And we have Arindam, right?
Yes.
Right? Yes, hi Arindam, how are you?
I'm doing good, sir. How are you?
You know what I missed about Arindam? And every radiologist has said this, whenever there's a case, Arindam would say, but sir, I have a doubt, which is very classic, which is awesome. I love that. Arindam would ask like really pointed questions, right at the moment we're like, wow, that's a great question. So welcome. Well, go ahead, introduce yourself.
As you said, like being a doctor, our journey as a student never ends. So
Yes.
we are always learning. So hi everyone, I'm Dr. Arindam from Bombay, India. I completed my residency last year in radiology, and I'm working as a consultant radiologist in 2 diagnostic center as well as in 1 multi-specialty hospital. That's my course, and I'm preparing for USMLE now, and hopefully I'm planning for either 2022 or 2023 batch. So let's see. Hopefully I get into it.
Awesome. Welcome.
I'm
welcome.
so happy to see you guys again.
Great. Yeah. Good to see you too. Good to see you. And we have Jane. Jane, how are you?
Hi everyone. Hi, Dr. Sami. It's very nice to see you here.
Yeah,
And thank you. Oh, yeah, thanks. If you'd like me to tell a bit about myself, then I have just completed the 2nd year of residency in radiology in Russia, and I'm currently a scribe, Dr. Sami's assistant, and I'm very enjoying this job. I hope for the further
Awesome.
very productive job together. Thank you.
Great, great. Thank you so much, Jane. Jane came to us as a student, actually, and she had amazing insights into things. And I had forgot to ask Rhonda, like, what's her background, whatnot. I was like, wow, she's really astute. And then she told me she's a radiology resident. So welcome and excellent work that you're doing with us. If you guys ever get onto Jane's screen, just watch her, how she scrolls through things, creates reports and all that. Very instructive. So welcome, Jane. All right. And then Shrisha, are you there? Can you hear us? I think they may be working. I don't know. Shrisha and Shravan are working.
Mm-hmm. Let me see if they can hear us.
Yeah.
Oh, so I can hear you.
Oh, hey, Shravan. How you doing?
Hi. Good. How are you guys?
How you doing?
Good, good.
Are you guys working right now?
Yeah, we're working at the moment.
Oh, okay. Okay. Yeah. You guys just wanted to observe, is that right?
Yes, if that's okay.
Absolutely. Yeah, absolutely. So Shravan is also one of my scribes. He's on sabbatical right now because he's off doing some studying for something, but he's going to come back to us more enriched and ready to work again. Right, Shravan? When are you coming back, Shravan?
Oh, for sure. Hopefully by the end of August, I'll be there.
Nice, nice. Okay.
And yeah, it's a pleasure working with you, Dr. Sami.
All right, well, thank you.
He's currently working with Dr. Kars too during the days right now.
Yeah, Dr. Kars. Is Dr. Kars on? Can she hear us?
Yes, I am on.
Hey.
Hey, Dr.
Hey,
Kars.
Shrisha, how are you?
Good. How are you guys? This is a great idea.
Yeah, thanks. We figure, you know what? We wanted to create something where we had some time and space to really just sit down and interact with the students on an educational level and not be under the pressure of reading. So yeah, here we are. So.
And right now it's saying it says Zoom is unable to detect a camera for me. So I'm trying to get my camera on.
Oh, okay.
Do you
No
see me
worries.
now? Wait, is it on now? I originally told Shrevin I wasn't going to show my face because I did not prepare, but I'm willing to, but my camera's not working.
Okay.
Okay.
All
Well,
right.
maybe it will.
Okay, no worries. We'll figure it out. Yeah, go ahead and do what you need to do. So,
And
all right.
Dr. Karsh, she's right here.
Yeah.
Like a stone's throw from Dr. Sami's house and a stone's throw from our office right here. So
Nearby.
yeah, it's great having Dr. Karsh a part of everything.
Yeah, it's wonderful to see such a international, diverse
That's what I
group.
love.
It's so interesting. I'm sure we're going to see some interesting cases because things vary from different parts of the world, you know?
Absolutely. Absolutely. Yeah. Well, welcome, Dr. Karsh. So
Feel
free to chime in. And if you see something interesting or have an insight or something, feel free to chime right in. Dr. Karsh, by the way, has 2 fellowships. One in musculoskeletal MRI imaging and ultrasound, right, Teresa?
Right.
Ultrasound, yeah. So she's a high-level expert in these matters. So
hardly, but thank you.
Great. Welcome.
Okay. All right. I'll chime in if I see anything.
Please do. Please do. Okay, so we only want to do this one time so we kind of get a general introduction. We're not going to do this every single time, but it's kind of nice to put a face to, who we're talking to. So Rhonda, now what we want to do is we'll be able to share the screen and then have like a panel of people on the side.
Yep.
So can I share my screen? I think.
Yep. Once you share your screen, then I'll be able to set it up that way.
Let me do this.
There you go.
Oh, here we go. Okay, awesome. So what I did was, I think just to kind of start is I have several videos here of actual cases that we've seen at Chicago Telerad over the years. And what we'll do is we'll just kind of go through some of these just to kind of get things rolling. We'll use the Socratic method, which you guys have heard me talk about, kind of the question and answer format. And I just find people just learn, much better with that method. In radiology, we call it the hot seats, right? Like, because that's just how, literally my first day in radiology, I was totally unprepared for what was going to come my way, right? Like I graduated med school, I did a year of clinical internship, and I show up in this conference room at 7 a.m. That's where we're told to show up. And one attending walks in, the chairman of the department walks in, chairman says a few welcoming words. There's 5 of us there. Like, all right, you're the first year radiology class. This is Dr. Anderson. He's going to start orienting you and all that kind of stuff. And we're thinking the first day is going to be, just a little bit of fluffiness here and there, and just like a regular orientation day. The chairman walks out, Dr. Anderson, and they're with us. And he puts up a chest x-ray right on the view box. Back then, we didn't have packs or nothing. We just had view boxes. Puts up a chest x-ray, takes out a pointer. And 5 of us are there. He goes, "What's this?" He's pointed right into the anatomy. So it was the heart. He goes, "Is this normal, abnormal?" And we just went one by one and just started, answering. And then he said, "What's this? What's this?" Literally for the whole hour, we just ran right into it. So I still remember that. I mean, I remember every one of those lectures and every one of those interactive sessions. I find things tend to stick when you're under a little bit of pressure, and you learn. So, but this is designed to be fun. I mean, there's the whole idea here is for you to make mistakes. You're going to fail your way forward, right? Like we all do on everything we do. So what I'll do is we'll go through some of these cases, and then we'll incorporate, we'll talk about some basic anatomy. We'll talk about pathology, pathophysiology, and differential diagnosis and whatnot. So as we go through them, I'm going to kind of share with you some pearls of wisdom and whatnot I've learned over the years, just kind of about medicine, radiology, and maybe even life in general to a certain extent. So, all right, so let's see if this works. I got videos of this here. I can get this to play. Here we go. Oh, this looks it's going to work pretty good. All right, so what I will do And I actually don't even remember these cases. I am looking this because I have a bunch of these cases, and I just randomly selected a bunch. So let's see. I want to get the display big, but it won't do that.
You can click the green arrow.
Yeah, you're right. Of course, you're right.
There you go.
Always. Okay, so all right. So what I'm going to do is I'm going to play the video, and we can stop. And let's see who's on our panel here. Let's. I'm just going to go. I'll ask for volunteers, and then I'll later on randomly pick people. So okay, let's play the video, and let's see what we got. So just take a look at it and just to try to absorb. Contrast. And you can see the right side cerebellum, there's a really decent station. Also the right temporal lobe. You can see multiple findings here. Go ahead and put your differential considerations in the comment section below. Non-contrast. You don't see much of the contrast images. Okay, so just we'll ask a volunteer. What did you see? What kind of exam is this? Is it with contrast, without contrast? And what are the findings and what are the differentials? So let's start with somebody who's a med student volunteer. Any med student?
And everybody can just feel free to chime in. Don't be nervous. Don't be afraid.
Yeah.
It's a very comfortable environment.
Absolutely. Who's a med student right now? I forgot. Somebody did say. Rhonda, you remember?
I can participate.
Go ahead.
That's
What is it,
Pedro.
Pedro?
Great.
Pedro. Go ahead, Pedro.
Okay, so I think it's a brain CT scan.
Okay.
With contrast,
Okay.
I think.
Okay.
I think I saw two circumferential lesions with.
Yeah.
So Dr.
That's
Sami, I'm
one.
sorry to interrupt you, Pedro.
Yep.
If Dr. Sami auto accepts all control, then each person is able to scroll through it and point out what they're seeing.
Yeah. For now, don't try to control the screen because I'm going to do some annotations and stuff, right?
Oh, okay.
Okay, for now, yeah. Go ahead, Pedro.
So I saw two circumferential lesions, well defined, with peripheral enhancing.
Okay.
Well, my guess is that it could be maybe brain abscess, possibly.
Okay.
Well,
so first of all, let's look at this image right here, right? What do you see on
right.
this particular image that I've circled?
I think we are in the cerebellum.
Okay. What part of the cerebellum is that?
That's the cerebellopontine angle, maybe.
Okay, good, very good. Yeah, you're at the cerebellopontine angle, close to the angle is actually the CSF cistern, right, or that juncture right there. But this is the right side. For now,
yes.
It is the right side cerebellum. So what do you see there?
It's maybe based on the location.
What is this here? Yeah.
Sorry.
Yeah, what is this structure here? Anybody else?
Structure.
Yeah, what is the structure here? Go ahead. Somebody else help them out.
Can I?
Yeah, go ahead, please. Go ahead.
It's a ring-enhancing lesion.
Yep.
So there are multiple of those.
Yeah.
I've seen some in the hemispheres.
Uh-huh.
I'm not sure if they are in the white-gray matter junction.
Okay.
but
Let's assume that they're kind of just everywhere, right? I'm going to show you the
so
video again here, right? And we'll just assume they're everywhere. So we'll go through the video. I'm not playing the sound part of it. Go ahead. So here's the images again. You
yeah,
see another
some
one there in the right temporal lobe. in the-
temporal,
yeah,
yeah,
it's all right.
also parietal, I think.
Yeah. Okay, so these are basically ring enhancing mass lesions, right? Do you remember the differential for that?
Yeah, the history would be very helpful, but those can be
Let's say it's a seizure history.
seizure history.
Yeah.
So probably either metastasis
Okay.
or some kind of infectious process, maybe the opportunistic HIV infection.
There's a mnemonic for this. Do you remember the mnemonic? Anybody know the mnemonic?
Magical dear.
Magic doctor, right? Who's
Magical
that?
doctor. Yeah.
Magic doctor, right? What is it? Tell us the entities on that.
The first one is metastasis,
Mhm.
like you rightly said, and one I think Pedro mentioned in the starting abscess.
Yeah.
That A stands for abscess, and then G, I think it stands for tumor glioblastoma, and this I, which I can't remember, inflammatory lesions such as tuberculoma or NCC, right?
Well,
So
intracerebral
then the-
hematoma typically, but yeah, go ahead.
Yeah.
That's yeah.
Yeah. So and C, I don't remember, and D is
Cerebral
for
infarct, right?
demyelination.
Subacute cerebral infarct, right? Remember that?
Infarct, yeah, subacute infarct, yeah.
Okay.
So D is for demyelinating regions, and R is for radiation necrosis.
Excellent, excellent. That's it. Do you guys get all that? This is a typical magic doctor case, right? So I think so the differential is wide, but this patient had a history of lung cancer. We held that back from you, but that's what it was, lung cancer, all right? So typical Mets everywhere. By the way, where does lung cancer want to metastasize to first? You know? Anybody know? Just say it out.
Breast and brain.
Yeah, brain. Brain. It loves to go to brain, right? Oftentimes people with lung cancer can present with seizures, right? All right, so that was our first case. We'll close that one out. And I don't even know what this case is, but we're about to find out here. Let's see here. I selected these randomly, so hopefully it loads. There we go. Oh, this is a good one. Okay, so I'll play it with the audio. These were all done in the office from a couple of years ago. We had all the scribes and all the students all together. So you may have some music or me talking in the background here. Let's try this out. We got coronal images. We think the differential diagnosis is based on coronals. We just talk about bone findings, right? To answers for that. Bones. Okay, so anybody see anything abnormal? Let's start with let's see, we get to the names now. Alejandra, let's start with you because I can just see you. What do you see? Does anything strike out at you there on this exam?
So I kind of saw like a pubic mass. Was it?
So let me focus you in on the bones, right? Anything abnormal about bones?
Some fusion on the sacral.
Without audio, yeah. So as we're scrolling through this, you may not. You're a med student, right? A recent graduate.
Yeah, yeah.
Okay. Okay, hang on to that. Let's see. Anybody else? Tell us. Except for Pratik. How about Shaba? No, Shaba is a surgery resident. What do you think, Shaba, about these bones? Shaba, you there?
Yeah. I'm thinking.
Good. Okay, couldn't hear you. Go ahead. What do you think?
there's maybe a problem with the density. There's a low density.
Yeah, the density. What's the problem with it?
Osteopenia.
Is it osteopenia? I'm going to put that again here so you can see. Here, let's put it right here.
Multiple myeloma.
What does multiple myeloma do?
It would give you like those punch out lesions.
All right. So is that punched out or what's?
No, it's like all together. It's so more bad, like osteoporosis.
No, it's not. It's not a problem of lucency, right? So I know Arindam is waiting to just jump out and say it. Go ahead, Arindam.
So it looks like cotton wool spots.
Okay. Yeah.
Paget. I'll go with Paget.
Oh, pages.
Yeah, Paget's disease, right?
Yeah.
Right.
Mosaic
Okay.
pattern.
It's like a mosaic pattern, right? So the bone density is what? It's too dense,
Increase.
right? So,
Yeah.
all right. So what happens when the bone density is too dense? Like, what's your differential on this? What's the differential diagnosis on Paget's
Could be
disease?
Mets.
Okay, what kind of Mets?
Mets,
What kind of Mets?
sclerotic Mets.
Like what?
Osteopetrosis. It could be osteopetrosis.
Excellent, excellent. Osteoporosis. So Arindam's a radiologist. That's why he knows all these things. But excellent. Osteoporosis. What is osteoporosis? Tell these guys what that is.
Increased osteoblastic activity. So it causes like multiple blastic lesions.
Well, that's, yeah, it's not blastic lesions. Arindam, go ahead. Tell them what osteoporosis is since you brought it up.
It's actually a so it's defect in osteoclastic activity.
Yeah, that's exactly right. That's where you get the density of the bones. We'll look at it, the next case, we'll look at the bones again. These bones are very abnormal. They're too dense, diffusely dense. So what happens to the structural stability of the bones when they become
becomes brittle actually.
Becomes brittle.
They're more
right?
prone to fractures.
Exactly. It's more dense. So it's counterintuitive, right? The bone is more dense, right? But it's more brittle. It's more prone to fractures. A little counterintuitive, but because the matrix is so abnormal. So there's a balance. Remember in pathophysiology, there's always a balance between osteoblastic and osteoclastic activity. Those two have to remain in balance at all times. When there's an imbalance, as we have here, you have defective bone. It's what you call an unstable equilibrium. You remember that from physics? Right? It's actually a living unstable equilibrium because both of those two have to be in balance. And with osteoporosis, it's imbalance. There's other things that give you imbalance. What other things give you imbalance between osteoclastic and osteoblastic activity?
Renal osteodystrophy.
Excellent. Renal osteodystrophy. Tell these guys what that means.
So basically there is loss of homeostasis between vitamin D metabolism and calcium metabolism.
Yep. Excellent. Excellent. Nice. So everybody got that? This is, I think, osteoporosis. I mean, now so osteoporosis patients usually never make it this late, but it's a very classic appearance, but I don't think this patient didn't actually have osteoporosis. They usually don't make it this late without fractures and all that. So what do we think this is? Pratik, what do you think?
So this could be sclerotic metastasis like you mentioned earlier.
Yeah, I think that's what it's going to be, is sclerotic mets. Pretty diffusely sclerotic, right? So this is a male. So yeah. What kind of cancer are we? Prostate, right? This is diffuse prostate mets. But the differential could include osteoporosis. It looks different. Usually osteoporosis are younger. They're going to come to clinical attention much earlier, right? Because they're going to fracture. You get an x-ray, it's going to look very abnormal. How do you guys, Jane, what do you think about Paget's for this case? Do you like Paget's for this one?
Well, actually, I was thinking for the differential, yes, including Paget's disease, since the structure is kind of irregular and both sclerotic and kind of lucent, well, inclusion is also present.
Yeah. Yeah, I like it less for Paget's just because it's too dense. Paget's kind of has like a trabecular appearance. So it just looks different, right? So,
Okay.
So, all right. Okay, that's a good one. All right. I forgot about that case from before. All right, let's close that one. Let's do the next one. Let's see. We have 20 participants now, Rhonda, which is great. I just don't remember who else is here.
It's me.
Oh, who else? Who didn't introduce himself? Who's that?
Yeah, I think it was me. I have not introduced myself.
Oh, that's okay. You introduce yourself. What's your name?
This is Abhinav.
Oh, Abhinav. Hey,
yeah.
how are you?
Good. How are you?
Good. Yeah.
Sorry, I was having trouble logging.
Oh, that's okay. No worries. Is that Maham? Maham, you here?
Yeah, hi.
Hey, Maham. Just introduce yourself. Maham is a daughter of a really good friend of ours, who's also our neighbor. So
I'm a recent med student graduate from Pakistan.
awesome. And Maha's a new mother as well. Just had a baby.
I saw you pop on there, Maham. I was happy to see you.
Yeah.
Hi.
Okay. All right. So let's see here. This case, I can't remember what this was about, but it's probably something good. So let's watch this here. So this is a 10-year-old, and this is imaging the bladder. And what do you think in the 10-year-old? Yeah, I remember this case. I don't. Rhonda, were you in the room when we did this one? I don't think so.
I don't know, actually.
I don't think you were. This baffled us a little bit, but so let's start with Maham. Hey, Maham, why don't you just tell us what you see? Feel free to make any mistakes. There's no right or wrong answer here.
Is there something in the lumen of the bladder?
Yeah. So tell us, what kind of study is this? What body part? Is
So, an ultrasound,
yeah, it's an ultrasound, right?
and then I don't know, it looks too like large and uniform to just be a stone.
Yeah. So here, let's use some annotations here and look. Okay. So first of all, it's an ultrasound because you see this kind of white and black and gray and all that. And the other thing you see is this transducer up here. You see my green line I'm drawing here. So fluid on ultrasound is black. You see this density or this echogenicity? It's black, right? Right. And because the sound, as it comes through here, it just transmits fast, right? It goes right through fast. And then everything that we see is echoes being reflected back, okay? So what we see here is this mass here, this 10-year-old. So what do you think, Mom? This is a 10-year-old, and I think the patient was asymptomatic, and I think except for hematuria. It's very unusual in a 10-year-old. We see this mass. So what do you think? What do you think's going on?
I have no idea.
Okay, that's fair enough. Anybody else? Anybody except for Arundam. All right.
Is that a bladder tumor?
Okay, a bladder tumor. Like what? Who's that? Who's talking? Say your name first, yeah? Who's that? I don't know who's talking there. Go ahead. Say your name and just
Was that Hema?
Emma. Go ahead, Emma.
Oh yeah. It was me that said that
yes.
if it was a bladder tumor.
Yeah, that's a thought in a 10-year-old. Anybody know a differential diagnosis for a bladder mass in a 10-year-old? Let's just including tumor, like what's just a general differential diagnosis?
Transitional cell carcinoma.
I think somebody said transitional cell carcinoma. So how common would that be in a 10-year-old?
I think it's common.
Probably not common, right? Not common. So let's put that lower on the list. What else? What else would there be?
This be like hypertrophy of the wall of the bladder.
I love creativity in a physician, and that's more of a zebra diagnosis. I haven't seen on Rhonda. Have you ever seen hypertrophy in the wall of a bladder like this?
No, especially not in a 10-year-old.
Not a 10-year-old, right? So, but that's an interesting thought. Okay, hypertrophy, but I've never seen it, but that's a thought. Anybody else?
Well, so hypertrophy is interesting. That is a really good thought. However, when I get a case of hypertrophy, I'll show it. I'll try to remember to bring it up to show you guys, but usually it's more of a kind of trabeculated, undulating appearance, and this doesn't really look like it's in the wall. This looks more like it's in the lumen.
Yes.
But anytime you see something like this, sorry, I just came in now because I'm reading case, but like, you want to turn these are just some things to remember. You want to turn the patient on their side, see if it moves. Is this a mobile thing? Is it stuck to the wall? If it moves, it's debris, and you're thinking blood, you're thinking infection, you're thinking maybe like kind of sandy stones. If it's stuck there, then you're thinking mass and polyp, benign, malignant, or a hematoma that's just stuck there. Or there's like these benign things that kids get. I can't remember all the names. There's like cystitis, cystic, something cystica.
Yes.
Is that what it is?
I think that's what it is.
I forgot what it's called, but it's
yeah,
like a tongue twister or something cystica,
yeah,
right?
yeah. This was a while ago, and I think we looked it up and we put it in. I forgot what I put in the report, but no, excellent. That's exactly what it is. That's exactly the differential. I mean, these are the things you think about, right? Common things being common, hematoma, infection, debris, all those kind of things. Yeah, that's perfectly said. Yeah. So let's see here. Let's see what else we can. Hey, maybe. Oh, perfect. Thanks. So, yeah, let's play this one more time and see if we can get any other information out of this. So this is a 10-year-old. The annotations. Bladder. Oh, this is what I wanted to show you guys. Look at the flow. There's no flow here. There's no vascular flow. Pretty sure you see that. There's not much. There's no color Doppler.
Yeah. So that makes it less
Yeah.
likely to be something really vascular and scary.
Exactly. Yeah. There's no color Doppler. That was a key point here. Yeah. So these, for those of you guys that don't know, these color dots are actually flow from vessels, arteries and veins, arterioles and venules, and we don't see any flow here. So probably something like a hematoma or debris, that sort of thing, infection, that sort of thing. Pratik or Jane or Arindam, you want to add anything to that?
Yeah, we could have tried moving the patient and see if it moves like she said earlier, and then we could have differentiated whether it's debris or a mass.
Yeah, absolutely.
This doesn't look like mass because mass will always be like lobulated or fungating. This is more of like a dependent debris. So it could be old hematoma or like debris because of UTI, cystitis. It's mostly favors that.
Yeah, excellent thoughts. Yeah. All right, great case. Okay, let's go to the next one here. Let's see here.
So, Dr. Sami, may I ask you a question once again in this case?
On this case, okay. Yeah, go ahead.
Just for the final, most likely diagnosis, how would you like call it? Is inflammation, finally?
Yeah, I think we called it debris. I think we called it hematoma. And it wasn't what it was. Yeah, because it wasn't any of those other esoteric entities because there was no color up flow. We didn't have any dependent images. This was just there was no dynamic images. So we just went with what they sent us. So I think we just call it hematoma. And then I think, if memory serves me correctly, I think there was a history of trauma somewhere, some remote history. God, yeah. Go ahead, Arindam. Yeah.
I'm sorry, did you say trauma? A history of trauma?
Trauma, yeah.
Oh, okay.
The hematoma will always have the shouldering kind of features.
Yes.
But debris won't have that.
Yes. Oh, that's true. Yeah. Yes. I think the other thing you kind of see some layering here. I think that was the other thing. are in them. Do you agree? Like you see this layering here? Like it extends, like it's not like a lobulated, it's not just, it layers here. So this could also go with the hematocrit effect. All right, so I don't know, not so much here, but here you see this debris that's here?
Yeah.
This all kind of goes, I think that's what we call that. I mean, hematoma infection debris, it may go all together, who knows, but.
It's also homogeneous.
It's also homogeneous. That's a great point. The exogenicity is homogeneous. It's not multiloculated. It's not, there's no calcifications. It's pretty homogeneous, pretty isoechoic, right?
Yes.
So, all right. Well, I think we've gotten all we can out of that one. Let's go to the next one, yeah? Let's see here. All right. I have no idea what this is. Let's see. We'll look at this together. All right. So this is a CT of the left upper extremity. And we're looking at the side. We should take a look. Anterior compartment. I think I said left upper extremity, but this is clearly left lower extremity. Something else. Maybe axial. So put your differentials in the comments down below. Yeah, I think I put this on LinkedIn, and there was a florid reaction from a bunch of people. All right, what do we think? Huria, we haven't heard from you. What do you think, Huria? Huria has some great insights as well. You there, Huria?
Yes, I'm here.
Yeah, what do you think? What kind of scan is this? What body part? And what are we looking
So
at?
it's the left leg. It's an axial scan, CT scan without contrast.
Mm-hmm. Is this the left leg? I didn't give you the whole perspective, but I'll tell you this is the femur. So what body part is it then now? It's
So
the thigh, right?
It's the thigh.
The thigh,
Yes.
right? Okay. So yeah, I'll play it without the sound here again. Go ahead. As we're looking at it, what are we seeing? What is that structure there we're seeing? That's the finding, by the way. Right here. Okay. What do you see there? You see anything, Huria? There, can you hear us?
Yes. Sorry, I can't find it.
You see the structure here? Let's see, I'll give you the measurement here. Let's see here. I give you measurements right there. You see it there? You see it now?
Yes.
All right. Any thoughts as to what that is?
So there's a hyperdense lesion in the muscle.
Mm-hmm. Okay. Okay, you see, I think one of the key things I want to point out to you, and tell me if you see this here. I'm going to annotate it, and you can tell me. I hope you guys can see there's a fluid level here. You guys see that?
Yeah, it's visible.
Yes.
The fluid level, right, Huria? So anytime you see a straight line in medicine, biology, physiology, anywhere, it's abnormal, it's pathologic. So when you see a straight line in imaging like this, think pathology. There's something wrong here. You should not be seeing a straight line anywhere in the body. Now, there are a couple of exceptions, you know, the midline falx is pretty straight, but when you're looking at axial imaging and you see a fluid, this is abnormal, right? So you've got this fluid collection here, right? This one is fluid, right? So any idea what muscle this is in? You may not know this, and that's okay, but just take a guess if you know.
Vastus intermedius.
Okay, somebody said vastus intermedius. Any other thoughts? Jane, what do you think?
Well, this is obviously quadriceps muscle, but I don't remember the bundle.
So it's the anterior compartment of the thigh, right? So what is that?
Mm-hmm.
Arindam, what is it?
Where it's well circumscribed cystic lesion with fluid level.
No, the question is what muscle is this?
Muscle, I don't know. I just know it's anterior compartment.
Yeah. Anybody else?
quadratus femoris.
Well, that's the whole bundle, right? So you have the answer is right. Vastus lateralis, medius, intermedius, right? Remember that muscle bundle is the intermedius, right? So anyway, this is the pathology here, right? So we're seeing this collection here with a fluid level in this muscle. So you have an intramuscular fluid collection. So somebody tell me the differential on this one here.
An abscess.
Okay, abscess is one. What else? Anybody else?
Hematoma.
Hematoma. Perfect, right? So why hematoma? Let's talk about abscess and hematoma. Why is that good for this? Why hematoma?
Layering of fluid.
Different.
Layering of hypertension.
Layering, right? You get that. What's that called? What do we call that? The hematocrit effect, right?
Hematocrit.
That's the hematocrit effect. Yeah. What other? This is a bonus question, but we see this all the time. What other? So this is a fluid level. It's not an air fluid level. It's a fluid level. Here's fluid right here. This is fluid, and then you got this fluid here. So what's the density of this fluid compared to this fluid? Anybody know?
It's more
Which
dense.
one's?
And
Which one's more dense?
the lower is more
Lower,
dense.
right.
And that's the reason why it descends.
It descends. Exactly correct. Yeah. So here's a bonus question. What other kind of fluid level do we see that we commonly see when you guys are reading with me? And we see this in a very particular situation that can happen almost anywhere in the body. What other? So this is the hematocrit effect, and that's blood and plasma, right? Where's the other fluid flow level that we see often, commonly, almost every night?
Jane, come on, you got this.
Go ahead. Who's it? Who said it?
Lipohemorthosis and trauma of joints. Whenever we see X-rays, then you mention it.
That's exactly right. Lipohemorthosis, right? So that's the other kind of fluid level. So okay, so let's stick with this. So what's the idea here? I guess on the pathology stuff, we'll go with our radiology people. What do you guys think on this intramuscular lesion, right? So what's the most important thing in radiology and real estate?
Location.
Location. And number two?
Location.
Location. Number three?
Location.
Location, right? Always, because when you guys make reports, for those of your scribes, and you put down in the impression, acute hemorrhage, acute subarachnoid hemorrhage measuring, and that's it. And I ask you, this means nothing to me. Why? Because it doesn't tell you where it is, right? Where's the vascular distribution? What's the clinical implication of where it's at, right? Because a hemorrhage impinging on the internal carotid artery is going to have very different implications compared to hemorrhage, just in the occipital lobe, right? Like isolated, right? Both are bad, but different implications clinically, right? So let's come back to this. So this is a fluid level cystic mass in the thigh musculature, right? What do you guys think it is? What's the differential here?
Is there a possibility?
Yeah, go ahead. Who's that?
It's Dmitry. Yeah. Is there a possibility that the person injected this into himself?
Yeah, that's a great thought, actually.
Like synthol?
Say it again.
Synthol, but it's an oil. We will see fat in this case. Synthol.
What is that? Synthol?
That's a synthetic oil that bodybuilders inject into themselves.
Oh yeah. Yeah, we see that in the Brazilian butt lift. Like they inject this oil without injecting. It's not like it's an implant. It's like an oil they inject, but unusual location. But I was thinking of some other kind of injection. You may have mentioned it, but I may not have heard it. But who else gets this kind of thing now that you mention it? Has to do with injections, right?
Steroid injections.
Unusual location for a steroid injection, right? But with a fluid level.
Diabetics.
Would steroid do this? What is it? Say it.
Diabetics.
Diabetics.
Somebody with allergies?
That's
Like
too deep.
Allergies. I guess I'm looking for the obvious one, right?
Oh, like a Lovinax injection? You mean like just like?
Well, I'm thinking IV drug abuser, right? Somebody
Oh,
who's injected and give you an intramuscular abscess, right?
Yep.
We've seen those, right? So that's kind of more the common one, right, that we've seen. What else? Okay, you got a fluid level. We established that we think it's hemorrhage, right? Because you have a hematocrit effect. So what else can do this? So okay, so abscess possible, right? What else? Common things being common.
Could it be a lymphatic malformation?
What kind of malformation?
A lymphatic malformation.
Zebra diagnosis, I think, right?
Spontaneous hematoma from blood thinners.
Okay, better. I like that one. I like all those, but we didn't get any history. I don't remember the history on this one. But I think all those are good. So some kind of hematoma, right? Hematoma and abscess are really kind of differential. So now those are the horses, right? Do you guys know, you've probably heard me say this many times, but horses versus zebras, right? When you hear hoofbeats in the desert, think horses, not zebras, right? So everybody has kind of this intuition, this need to see the diagnosis you're studying in your books in your patients, like walking around all the time. It's just simply not the case, right? Common things are common. A lot of stuff in imaging is just mundane, and uncommon presentations of common things are very common also. The uncommon things just don't occur that much. So I think we call this, we give a difference, I think, intramuscular hematoma and abscess formation. Because I think there are more too. Let me go back to this and look at it. Yeah, this is
there a possibility? I'm sorry.
Go ahead, Jane. Yeah.
Is there a possibility of mass and destruction within?
Yeah. What kind of mass?
Well, rhabdomyosarcoma or.
Yeah, zebra diagnoses, right? Absolutely.
Yeah, it is.
Absolutely, because I think there was like a second one here too. I think there was a second one here. Yeah. Right here, right? I think there's a second one there too.
Oh, yes.
So, and I think we mentioned that too. So we did mention a couple of zebras in the report. Just because there was a second one. It was just a strange kind of case. So yeah, and look, there's vascular calcifications in the femoral artery profunda, right? You see that down there? So it's a vascular path. So maybe they're on thinners, maybe something else is going on. So, all right. But that was a pretty cool case. Any other questions on that one?
Could it be a myxoma? I know that's a zebra diagnosis, but
Could be. I mean, weird things happen all the time. So I guess as long as you cover the main ones, and it's fine to throw in a few zebras. So I tend to put in, the two most common things.
Yeah.
Right. And then maybe a third common thing if it's like a common occurrence of something and it happens at the same time all the time. And then maybe a couple of zebras in there, and then we'll get a call from the physician. Like, what the heck is this? Or, I'm in a small rural hospital. We don't have MRI. We can't do anything with this patient. I need something, simple, So that's what happens. All right, let's go to the next one here. Okay, so let's do this one here. We'll play the video and we'll see what we got. The initial non-contact CT brain. Images here. Let's images. And we see the findings here. A week later, images. And here's the finding. So what's happening from differential considerations down below. Okay, this was a great case. So let's I don't have the names here. I know Rhonda, you gave it to me. Um, okay, so let's have one of the med students or new graduates tell me what you see. I'll put the audio off and then we'll just scroll. Just describe what you see and what happened. Okay, what kind of scan is this? Is it with contrast, without contrast? What do you see and what's your differentials and what happened between the old exam and then the current exam? Go ahead.
Right, it's a CT brain with contrast.
Uh-huh.
Right.
Well, say that again. It's a CT brain.
With contrast?
No, it's not with contrast. Right?
Oh,
We'll go over contrast probably in a separate video and teaching session, but we might as well look at it now here also. So when we say it's with contrast, what we mean is the patient has been injected with intravenous iodinated contrast, right? Because the iodine is there because it increases the density of the vessels. It enhances the vessels. When the x-rays go through it, the vessels appear as dense. None of these vessels are opacified, okay? Just so you know. So this bright thing that you may be looking at, this bright thing here, right? Right here. I'm going to circle it for you. Right there, right? So this bright thing here, right there, right? That's not contrast. So what's the other thing that can be dense and show up as an accumulation of fluid there? Do you know?
Chloride plexus.
So
chloride plexus.
Where's that located though? Chloride plexus. And what does chloride plexus do?
Oh, it's in the ventricles. It secretes the CSF.
Perfect. Okay. Now where is this located right here?
Oh, it's not here. It's
so ventricles are here, right? This is what?
Right.
What's this? What's the structure?
Septum. Wait, which one? Oh, this is a lateral ventricle.
That's the lateral ventricle. So chloride plexus is going to live there, right? You can't see much chloride plexus here, but that's where it's at. But this is where? What area is this?
What's the epidural area?
It's a subdural.
Subdural, right? Yeah.
Is it a subdural hematoma?
Yeah, so subdural, right? So if we go through, let's see here, let's clear that, and let's play again. So this is the current, I think that's what I said. That's the old, this is the old CT brain, non-contrast, right? A week later. Now what happened? Okay, so let's look here. So that's Diana, right? Yeah. So what happened here? What happened now?
This is a subdural hematoma or hemorrhage.
Yeah, it's a subdural hemorrhage, right? Because what you see is this whole space, right? Space. It's gotten bigger, right?
Yeah.
Right.
It's also, you see these densities here. So what's the other? So hemorrhage is dense. Why? Because of hemosiderin, right? So it's going to show up as dense. That's how we differentiate hemorrhage on CT brain, right? So subdural hemorrhage that occurred before is a small one, and now it's suddenly bigger. So what happened in the interim? Why did this happen? Anybody know?
It's bleeding again?
It's acute on chronic.
Yeah. He said it. Is that Arundam? Said it?
Yes. Yes.
So tell us what that is, what this process is.
So it's re-bleeding. It occurs because of re-bleeding, the stretching of meningeal vessels because of the pressure.
Right. And why would this occur in this patient?
I saw one calcific density. Was it calcific or fresh blood? Because
where? Right here?
Yeah,
This
that
thing?
one. Yeah. Yeah.
No, what is that? What density is that?
No, it looks similar to bone to be. So I thought it's more of chronic, like very old chronic, because chronic SDS can calcify.
Yeah, I don't have the windows to show you here, but if you look, I mean, let's see. I mean, let's see. I can't zoom in either.
Is it the middle meningeal artery or?
No, this is not as dense as this, Arindam. This is not as, if you look closely, right? It's not as dense. And your point is well taken because I did window it and I went to bone windows and the bone was obviously more dense. So that's the way you check for it, for the chronic, but it was acute. That's how you know it's acute, right? Because you go to the bone window and you're going to look at it and hey, it's not as dense as bone. It's soft tissue density. It's going to be like Hounslow units of 50. And we'll do a separate talk on Hounslow units, right? So that's what, that's acute, right? So then what happens is, that was acute hemorrhage. So the question I'm asking is, what happens between here and here? Now we're looking here.
Could it be a recurrent?
Midline shift.
Can you show it again?
Midline shift.
It's not really shifted that much. No, but what's the finding? Jane, what happened between the first one and the second one here?
Well, you mean in terms of the history of the patient or in terms of the radiology findings?
The radiology findings. Yeah.
Well, I can see that the hematoma probably, well, it is enlarged, obviously, and I can see that it's heterogeneous in appearance, which means it's probably organizing.
Yeah, exactly. So what kind of patients get this kind of finding? This is only, I think it's a week interval, right? So a little bit of acute hemorrhage. A week later, they come back, maybe they have some mental status change, something's going on. And they come with this, like, what happened? So like, what's the patient, what's the clinical history of the patient?
He might have suffered a recurrent fall.
Yeah. And what kind of patients get subdural hemorrhages with recurrent falls?
Elderly.
Older patients.
Somebody say alcohol.
Probably he's on anticoagulants.
Yeah, who said that?
I said that.
Is that
Arindam,
yeah, anticoagulants, right? Somebody's taking some kind of anticoagulant. They come back. Minor falls, by the way, minor falls. Like I've seen patients fall in front of me and I'm like thinking, okay, that wasn't a big deal, you know, or even from a sitting position, you know, fall. And that's not that big a deal. Like, no, let's get the CT brain. And sure enough, there's a big subdural hemorrhage. So it doesn't take much trauma. So this is acute. This is acute on chronic. So that I think there's some more interval areas of hemorrhage. So these are acute here, the dense areas right here. So let's annotate that and show you. So this area right here, that's the more acute. These are acute because they're bright, right? These areas, this area, this lower density is chronic. It's also subdural blood, but it's chronic. So maybe they fell, you know, the day after that one CT brain, had a bigger subdural hemorrhage. Over 6 days, it started to resolve, but then they fell this morning and now they got a little bit more, right? So some of these areas. So this is acute on chronic subdural hemorrhage. That's what that is. Somebody said midline shift. So let's take a look here at the midline. Let's see if we can, this is not an exact, it's pretty straight. I don't know. I guess somebody could split hairs and say, well, maybe there's a little bit of a shift here. Maybe, I don't know. Maybe. I don't know. Jane, would you call it a midline shift?
I would.
Yeah, I guess there's a little bit. The thing is, look at the front and the back. I guess they haven't shifted. I don't know. I don't know if that's really the midline. I don't know if this is the midline here. Maybe it is. Let's look at it again. I could be wrong here. Let's see. Let's look at it.
May I ask you a question?
Yeah, go ahead, Jane.
So is there any particular level at which you should measure the shift or like the let's say the brainstem origin or somewhere? Yeah, the lateral ventricles.
Just above the lateral ventricles is kind of where I do my measure. Yeah, and I guess there's, if I go there, according to my own criteria, where I go to, I think there is some midline shift. Let's see. Let's see what it shows. This is the first one. We'll come back to it. That's showing the, that's the one from a week ago, and then now the current. Let's see. Yeah, maybe. I think it's exactly that. So maybe it's a little midline shift. This ventricle is a little effaced here on that side. So, okay. A little midline shift there. Any other questions on this one? Okay. Let's go to the next one. Rhonda, how are we doing on time? Are we?
As in what time is it? It's 2:08.
Okay, we only got 3 more, so maybe we're gonna wrap this up here, maybe 10 or 15 minutes. Here was an abdomen case here. Okay, we'll try to move along through these. It's already been an hour. What was that?
I know it's fun. We could just keep going and going.
I know, right? Keep going. Okay, so this is a really interesting case. Bilateral hypertrophy and hypertrophy, and they come down. They have the pelvis. Go through this from this. We're going to recon here. Look at that. That's pretty impressive. The bone. Both. Notice one more screen. Oh. Okay, so that's an interesting case here. I'm going to put the audio off and we'll just go through it. So, Jabba, what do you think on this abdomen pelvis? You're the surgeon. You're called for this in the middle of the night. What are you looking at here? Jabba there.
Yeah, I'm just watching.
What do you think? What kind of exam is this?
Oh, it's a CT scan of the abdomen and pelvis.
Okay, is it with contrast or without contrast?
With contrast.
It's with contrast, right? So what are the major findings here? What jumps out at you here as the surgeon? Anything?
Yeah, is it a female patient?
Does it look female? Yeah, let's try it
Thinking
again.
about the structure, whether it's the bladder or the uterus.
Okay. What do you think? Take a stab. What about Dr. Shashi? Shashi, you're a radiologist, right? We can't
Sorry,
hear
no.
you. Yeah.
I'm a medical. I'm a recent graduate. Yeah.
Oh, so what do you think? What kind of exam is this? And what's the finding that strikes out at you?
This is a CT scan of abdomen and pelvis with contrast, and I'm not sure, but this appears to be like bladder
Well,
outlet.
hang on. You said with contrast. What makes you say that? Do you see any vessels enhancing?
Yeah. The blood vessels appear more prominent. Yeah, I think this is due to the contrast.
No, the answer is no.
Okay.
Those are not. There's no contrast in this exam.
Is it a KUB?
Here's axials, right? What is that? What are these bright things here?
Atherosclerotic.
They're atherosclerotic calcifications, right? So, all right. So, Shashi, so what is anything strike out at you here? This any abdominal finding?
To me, it appears like a bladder outlet obstruction.
Okay, good. Okay, good. And what are the findings here that we're seeing on this coronal image? Tell me the whole picture. That's part of the picture.
There's a catheter within the bladder.
Okay, there's a catheter in the bladder. What else is in the bladder? So let me go back and here. I think this one.
There's a balloon. Yeah, is it a Foley?
Okay, so let me radiology. Everything is about subtlety in radiology, right? So let me show you here. So if you look, so you have this structure, right?
Yeah.
Okay, so what's this structure? This big structure here.
The bladder.
Bladder. That's the bladder. Okay, now what about this?
It's a blood clot.
Wall.
What about this? You see this density difference here? You see the density difference here?
Yeah.
That's the ball, right?
Bladder hemorrhage with organizing clot.
Okay, that's
Surgical
one.
intervention.
That's one. Who said that? That's Pratik?
Okay.
Okay.
Also, the patient has sclerotic mets. There is vertebral plana.
Okay, good observations. Yeah.
And prostate is diffusely enlarged with irregular borders.
Mm-hmm.
This is mostly organizing hematoma post-intervention because there is urine crescentic urine collection can be seen properly. Foley's catheter is inserted properly.
You're so close, Arindam. You're on the right track. And then you kind of veered off.
Could be a mass.
Okay, like what?
Like first, it is within the bladder. So first will be transitional cell carcinoma, and the second will be prostatic mass because of the sclerotic mets. The possible sclerotic mets.
Yeah, this is prostate cancer. This is a huge enlarged prostate protruding into the bladder lumen. This Foley catheter is actually in the prostatic urethra. You see this here? That's in the prostatic urethra. Right here. This Foley catheter right here. This is the Foley catheter. This is the balloon of the catheter, right? That's the prostatic urethra right here. And this is the base. This is the prostate. This is the prostate all around, right? The prostate's enlarged so much with the hypertrophy and the cancer that's protruded right into the base of the bladder. That's why you get that bladder outlet obstruction. And then, as Pratik mentioned, you got the sclerotic mets. That ties it all together right here. You see these sclerotic densities, and you got these pathologic compression fractures here.
Sir, but without contrast,
retrograde
contrast, how can we conclusively say the location about the catheter, Foley's catheter?
Yeah, we can't, right? But just having seen enough of these over time, the probability is that that's where it's going to be, right? Especially given the bladder outlet obstruction, right? Because why would you have a bladder outlet obstruction otherwise? If this is all hemorrhage, would you get a bladder outlet obstruction like this to this degree? Let's look on the coronal images here. Clearly those vertebral bodies are sclerotic, right? Look at all the sclerosis, the mets there.
Sir, in this case, how can we differentiate whether it's a clot or a mass?
I think, yeah. Before we even go to the MRI, look at the bladder outlet obstruction, right? So you got bilateral hydronephrosis and hydroureter, right? So look at the renal pelvises here, right? Those are enlarged, right? For those of you who can't see it, here, I'm going to point it out here. Let's see. Okay, ignore that. So look at this renal pelvis. It's all renal pelvis, right? It's enlarged, right? Here's the ureter on the left side. So if we let this play again, that this is, as we're coming down, we see this hydronephrosis, right? Bilateral. Now you see the ureters right here. You see right there. You see right there. As we come down. Okay. So look at the density of it. There's a couple of things, Arindam and Pratik and Jane and Dimitri, right? So if you look at this, kind of a pretty sharp angle there, right? That's pretty sharp. It's a little too sharp for a hematoma. Would a hematoma give you those sharp angles, you think?
Sir, but anteriorly the bladder wall can be appreciated. Posteriorly, it's not.
Mm-hmm. Yeah, fair. I mean, good point, but.
Should we do this case?
Yeah. What do you say, Sharisha?
Yeah, they are probably working right now.
Oh, they're working. Okay, got it.
Can I say something?
Yeah, go ahead, please.
Also about it has to be a soft tissue density, and it has to be elastic because they blew up the balloon. And I think that hematoma would disintegrate to some degree in this case.
Spread around, right? Or spread around. Yeah. It would move out. You would not, if you blow up a Foley catheter into a hematoma, it's not going to come. Look at this balloon, how it's compressed. I mean, it's really having a hard time expanding, right? That's another clue. Like, it's tight all the way around it. And plus, if you look here, it's a little more dense at the top. So it's a little irregular in terms of its density. So, like right here, you see that? You see the density there? Right there, right here. You see that? I don't know. Hematoma for me doesn't do that's pretty sharp. Hematoma is usually not that sharp in terms of margins. So prostate cancer with MET, somebody said it. Prostate cancer, bladder outlet obstruction, metastatic disease with pathologic fractures. All right.
So, but considering the size of the lesion invading bladder, the grade of hydronephrosis, the degree of hydronephrosis is not that much actually.
Well, that's pretty bad.
Well, the degree of hydronephrosis is pretty okay, probably just because they was compensated until recently with a Foley catheter.
Yeah, that, and also what else is probably his patients in some degree of renal failure, right?
Oh yeah.
Maybe their kidneys just don't work like, you know, young, healthy 22-year-old kidneys, right? So that's what it is. But yeah, that was a pretty impressive case. Any other questions in this case? We'll go on to the next one. And then maybe we'll do one more and then we'll probably wrap it up for today. Okay, so any questions at all in general? You guys can ask as well. We'll do one more last case. Yeah, we got this to load. All right, another abdomen case. Okay. Okay, so take a look at this case. We have absolute post contrast. So here's one finding. Let's go back and forth here. So I'm coming down here. Nothing there. Just drawing these. So what's going on? Love to hear your thoughts. Thanks. Okay, so I think I posted this in the chat yesterday. So yeah, what are you guys' thoughts? Arindam, let these other guys jump in here for a second. Yeah. Shaba, let's start with you since you're the surgeon. Yeah.
There's a mass on the left kidney.
Okay. First of all, what kind of exam is this? What kind of technique was used? Okay. Is it with contrast or without contrast?
With
and what kind of contrast? What kind of contrast?
With IV contrast.
IV and what else?
Oral.
There's oral contrast, right?
Oh yes, there's oral as well.
There's oral contrast. Okay. So you see, what do you see here? What's this finding? Here's a finding.
So there's a 73 millimeter in diameter, the mass.
Where?
Superior part of the left kidney.
Okay. Does this look aggressive or benign? Shava?
Looks benign.
Looks, well, let me rephrase that. Do the margins look aggressive or benign? Your answer is correct, benign, right? Because they're smooth margins. They're sharp, kind of smooth. However, the mass is what? Would you call this suspicious, or would you not worry about it, or what? What would you do as a surgeon? You're looking at the CT scan.
I would take a biopsy.
Shashi, what do you think?
Yeah, I think a biopsy.
Pratik? You're shaking your head.
this looks suspicious because there are areas of enhancing soft tissue within the lesion. So, in kidney masses, whatever I have heard, they are usually excised. They are never biopsied because of the possibility of spill.
Yeah, you don't, yeah, you don't want to biopsy this thing, right? Because you want to take this whole thing out. It's already suspicious enough, all right? So that's the renal cell. That's the renal cell carcinoma, right? And so when we look at this thing, I'm looking coronals and we see this other thing in the right lower quadrant. What the heck's going on here? Let's see, did I give you a measurement on this one here? Let me see if I stop. I should take static pictures when I do these. Let's see. So somebody else tell me what they're seeing in the right lower quadrant. When we get to here. Let's see. So that's the left. So this is very suspicious for renal cell carcinoma. So you guys see that on the left. Okay, so on the right, what the heck is that? Somebody tell me. Dimitri, what do you think?
Yeah, actually, me and Renal were discussing this case in the chat, and my first impression was that it's some kind of bowel related, and maybe it's the bowel itself. But then I looked at it closer, and I think there's some mass with necrotic density, hypodense, and enhancing on the periphery. So it's. I wish I could take a slower look at it, so I could follow the bowel through. But
well, let's just look at the image here for now.
It definitely looks like a sickle mass.
So does it look benign or aggressive? In terms
it definitely looks aggressive. It looks like a malignancy, maybe a carcinoma, or less likely, probably GIST tumor.
Okay, and what's happening with the margins of this mass?
They're irregular, they're enhancing, and the enhancement is pretty thick. So the wall is pretty thick, and inside we can see hyperdense material, which is probably necrotic in this case.
So if you look here, if you look at this, this is the mass because you can't see it, but look at the irregularity of it. It's just very ratty. Look at the vascular recruitment around. This is really irregular, aggressive mass lesion. So one of the concepts I wanted to illustrate with this is something called satisfaction of search, which all radiologists deal with, is that you find one finding, like I saw the renal cell mass, and we got everybody in the room got excited about that. And I said, hang on, let's keep going, let's keep looking. And then sure enough, here's another mass. So how common or uncommon is it for patients to have two concomitant separate malignancies at the same time?
Not that uncommon lately.
It's not that uncommon, yeah, I see it.
It happens. It happens, yeah. It's not that common.
Bilateral renal cell carcinoma can occur in von Hippel-Lindau syndrome.
Yeah, but we're talking about de novo, two separate malignancies, right? So this is going to be some kind of, adenocarcinoma, mucocele type cystic mass, lesion, neoplasm, metastatic disease. What else? What's the other differentials for all this stuff here down here in the right lower quadrant?
Are there any history available for this patient? Like
no history.
No
history other than abdominal pain. That was it. That's the history we got. Abdominal pain.
It could be an appendicular lesion, like appendicular abscess. If we think of like the patient is presenting with fever, abdominal pain, and those kinds of symptoms.
Yeah. Yeah, that's a thought, but it doesn't look like typical.
Yeah, it doesn't look like a typical abscess, but
it's really kind of, you see, we were looking at, could this be a terminal ileum lesion? Because if you see the markings here, the small bowel, is this really cecal? Is it terminal ileum? But it's some kind of neoplasm because it doesn't have the fluid or kind of the abscess features that you think of a perforated abscess or appendicitis. I haven't seen any evidence for appendicitis. There's an entity, there's a mucocele of the appendix. It's a neoplasm that can
Mucoadenocarcinoma of appendix.
mucoadenocarcinoma. I've seen that a couple times. Doesn't, I mean, that could be this. Who knows? Either way, it has to come out. Arindam, go ahead. What you're jumping out?
Sir, I had a doubt, like, why can't this be like subcapsular abscess? Because it has got septations, irregular wall.
Yeah. Could be. I don't know. We were leaning more toward neoplasm, I think, because we saw this first one, and the history. There's no white counts. There's no fever. There's no. We talked to the physician on this one. They said no white count, no fever, just generalized abdominal pain. So
Because this is definitely not definitely not arising from bowel, because there's no bowel loop dilatation. There's no lead point indicating where it is like it's a bowel origin.
So
Neither
it could be
appendix.
like it could be that mucoadenocarcinoma of appendix, or it could be a cyst.
No,
And
but
there won't be any obstruction.
that compresses the junction, and there is dilatation of small bowel loop, even in adenocarcinoma of appendix or mucocele of appendix. This doesn't look like mucocele.
yeah, I think so. If you have it at the cecum, right, the tip of the cecum, would you get proximal dilatation of the terminal ileum or ileum?
Retrograde dilatation.
No, if it's at the tip of the cecum, right? Because where does the ileocecal valve sit?
Off.
Here's the ileocecal valve right here. See it?
Yeah.
Yeah.
This is the ileum right here, and this is below that. So you're having, because why is this the ileocecal valve? Because there's a little bit of fat, right? That valve has a little bit of fat around it, so that's how we identify the ileocecal valve right there. This is sitting below that junction, right? The ileum doesn't attach right at the base of the cecum. It's 2 to 3 to 4 centimeters above that, right? You remember? If you remember from your lower GI studies, it's very variable where the ileocecal valve will sit on the cecum, right? Have you done the lower GI study? Double contrast lower GI study? Arindam, you've done that, right?
Yeah.
Remember where the ileocecal valve sits, and sometimes you get a retrograde backwash ileitis. So it's never at the tip of the cecum. So just from anatomy, we can exclude.
So but any pathology of appendix will protrude into cecum, and it will produce those shouldering, again that inverted umbrella sign, and all those specific.
Not necessarily. Not necessarily. No, the appendix is very variable. You could have. I've seen mucocele of the appendix hanging way out into the pelvis, not protruding into the cecum. They're growing the other way.
Because there is periphery fat stranding is there, so it's aggressive. Either it could be inflammatory or neoplastic.
Yeah, again, and then here's a few lymph nodes. This is the other thing that tipped it off to the. Look at these lymph nodes here. Now you could say they could be reactive lymph nodes. They're not pathologic yet, but now if you take a step back and you look, you still see some of these lymph nodes. So it's a differential, but we were leaning toward, some neoplastic etiology. Could it in fact be, perforated appendix and appendicitis? It could be. Yeah, I wouldn't exclude it necessarily, but I don't know. No, we just we didn't get any feedback from them. So, but the no fever, no white count, that really tipped us away from infections. So, anyway, any other questions anybody has on this case or anything else? I think that was the last one. Do we have one more? You guys want to see one more and then we'll call it quits?
Yes, sir.
Okay. Last one, and then we'll let everybody go. Oh wow, it's 2:30. I think we have a meeting on it. It's 1 second. Let's do this last one and then we'll call it quits here. Oh, can you guys hear me okay?
Yes. Yep.
Okay. Okay, good. Let's see here. Okay, it was last case. Okay, so, all right, here we go. Look at this case Okay, so all we got is coronal images, right? So let's have one of the non-radiology people describe what we're seeing here. What do you guys see? Who hasn't said anything yet? I don't know the names. I don't know the names. How about Alejandra? You there?
She
She
had to
actually
leave
had to leave
earlier.
and go to work.
Oh, okay.
Yeah, she left about 20 minutes ago for work.
Sure, sure. No worries. Yeah, go ahead. Anybody else? Just anybody describe what they see.
Well, it looks like a comminuted fracture of the distal tibia and fibula
Okay.
with articular involvement and very severe displacement of the fragments.
This
Okay.
possible trimalleolar fracture?
Yeah, there's a trimalleolar fracture, right? We
Yeah.
didn't get the sagittal images, but you can see on the sagittal images that there was a fracture there at the posterior malleolus too, right? What other feature is there that we see in this that we talked about earlier? Kind of briefly, somebody mentioned, yeah. You got the fractures, and what else? You can kind of see it.
Can you replay?
What is it?
No, I was just asking you to replay the video.
Yeah, there it is. Yeah. Has to do with fluid, right? What kind of fluid is going to be in the joint?
Oh, Lipohemorthosis.
It's a lipohemorthosis, all right? So
Yeah.
what does lipohemorthosis mean? Huria, what does lipohemorthosis mean?
It means there is a fracture, like a
I was asking Huria. No, Huria.
fat fluid level. Oh, sorry.
Huria.
Because of the fracture, there will be double density sign. The fluid will be leaking out.
Yeah, so what does lipohemorthosis mean?
It means there will be blood, and we'll see the hemocyanin sign.
No, lipo. What does lipo mean?
Fat.
Fat.
Fat, right? So why would you get fat in the joint?
From the bone marrow.
From the bone marrow, yeah. When you get fracture, you're going to get bone marrow leakage. That's the fat. And from the bone marrow, you're also going to get the blood too. So you get a lipohemorthosis. It's not a great example of it, but we'll show you another example. Typically in the elbow, you can see it. In the knee, you can see lipohemorthosis. So anyway, this is a trimalleolar fracture with some dislocation, I would say, of the ankle and lipohemorthosis. Pretty common type of fracture that we see.
Sir, do we give the grading and staging like the Weber C? We just mentioned trimalleolar fracture.
Yeah, it's a good question. And you can go to town with grading. You know, there's like there's a whole book, a thick book that has gradings and classifications and all that. And initially when radiology residents and fellows come out of practice and they start practicing, they're, you know, I give some gradings like shot scare type 1 fractures of the tibia. You know, we use some grading here and there, but if you have gradings on everything, the clinicians will get very, very upset, and quickly you'll hear from the chairman of the radiology department say, hey, stop using grading systems. You know, Colles type fractures, you know, I mean, for avascular necrosis and those things, I use gradings, but I didn't use gradings for everything because half the time, not half the time, I would say the vast majority of the time, nobody's going to know what you're talking about, right? I'll just stop sharing so we can all see each other. Yeah, nobody's going to know what you're talking about, and they have to go look it up. And if they got a busy emergency room of 30 patients, and you tell them, you know, there's a Schatzker type 3A fracture of the knee, they got to go look. They don't want that. You know, they want to know: is there a fracture? Is it displaced? Is there a hematoma? Is there a foreign body? Just give me the meat, right? Like, so you kind of have to dumb it down to like a 5th grade medical education level, if there's such a thing, right? Like really just really simple concepts so they can understand. So yeah, I don't use the gradings and all that. I used to do that. When I came out of fellowship and I was practicing, I mean, you know, grade this, grade that, and, you know, I'm looking great, the reports are great. And then after a while, you know, the first hospital practice I was at, the chairman came and said, hey, you got to stop using all these grading systems. I'm like, why? This is what we're supposed to do. This is, you know, our job. And it's like, nope, nobody wants it.
Because lately here, orthopedicians have started asking thoracolumbar injury scores and all that. We never used to give that before.
You may get one or two here and there that, ask for this, that, and the other thing. And some specialized practices have, unique needs, right? There was an imaging center where it was all neurosurgery patients, right? And they wanted they wanted detailed measurements of every seroma, every disc bulge and protrusion. So I got in the habit of doing it. I couldn't break that habit. So that's why if you see me doing lumbar spine MRIs, I'm measuring everything, right? I have you guys measuring it, right? Right, Jane? How many janky lumbar spines have you measured?
Yes, a lot. And we do measure it here too.
Yeah, and you guys measure there, right? Too. So
yeah.
It's kind of like, where you were trained and brought up. And, I meet radiologists who don't measure anything. In fact, one of my colleagues, Dr. Samir Shah, he's the vice president of Radiology Partners, the $1 billion radiology company. He doesn't measure hardly anything. He goes, why are you measuring this? Like renal cysts and hepatic cysts and stuff. I go, just out of habit. I mean, it's like, that's how I grew up in radiology, was measure how soon. Like, stop doing it. Nobody wants it.
Recently just stopped doing it.
I recently
Because of him,
stopped doing
actually.
it. I recently stopped doing it. So, it's different. Like the real world is different than academic practices and training. Like once you get out into the real world, it's like, oh, they don't want this. They don't care what I have to say about this. They just want to know the meat of the matter, and they don't want me to miss anything. That's what they want, So, did you guys find this useful and helpful, instructive, all that stuff? Yeah.
Yes, this was very useful.
Yeah, great. So the chat is there for you guys. If you guys have topics that you want us to cover next time we do this, I think we'll do this weekly, probably, and we can go through cases, we can go through anatomy. I kind of like the problem-focused method because then, when you have a problem, you can review the anatomy. We didn't go into too much detail on anything. We might do less cases next time, but more detail and drill down into things. So there's a wide variety of knowledge and experience here, so it's a little hard to tailor, but I always like doing basic stuff. I think it's really important to focus on the basics. So basic stuff like chest x-rays, plain film. So for you who are non-radiologists, I think it's incredibly important for you to know how to interpret chest x-rays, plain films, extremities, basic CT anatomy, like CT brains. It's not that hard. It's, just takes repetition and experience and so forth. So
I think something additionally that I want to add for future sessions that we have, our RADs that we have, Jane, Dimitri, Pratik, Arnam, if you guys have a cool case also that you want to actually point out and share your screen here, and we can go through all of that too across the board. I think that would be really great learning too.
We can save your cases for the next time. What we'll do is we'll divide into 3 sections. We'll do like 20 minutes of like basic stuff, right? So we'll focus the first 20 minutes on the non-radiologist in terms of plain film interpretation. I think it's a great place to start. And then we'll do 20 minutes of some of the cases that we had seen from the previous week. And it may not be enough, but we'll see. But then we'll do maybe 20 minutes of new, interesting, unique cases. It just depends on what we see during the week. Sometimes some weeks we get a lot of phenomenal, amazing cases that we just got to show people. So, yeah, this was great. Any other questions anybody has? All right. Well, thank you, Rhonda. You can conclude everything.
Yeah, thank you, everybody. This is
Sir, can we have
Thank you.
discussion, brainstorming session kind of thing?
Brainstorming for what? What kind of
like
brainstorming?
case discussion for people who are applying for FRCR or something like that.
For case discussions for
like brainstorming kind of stuff.
Brainstorming, sure. Talk to Rhonda about it, and we'll figure something out. Okay.
Yeah, we can definitely arrange something.
We'll figure something out. All right.
Like
okay, guys. Sure. Absolutely. All right, guys. Thank you very much. Okay.
Thank you very much.
Thank you.
Thank you, Dr. Sami.
Bye.
Thank you.
Bye.
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 Bye.